to for some people. But anyway, so as I was saying, we've been running these international grand rounds since Corona, since COVID, for surgery, and we've been able through the various hospitals affiliated with Azrieli to have some really good speakers from the United Kingdom, from the States. We even have done live surgery from Naharia and from I think Poria through these Zoom sessions. And I thought it would be nice to then see whether we could do it for medicine and for basic science. And this is our first international grand rounds for something non-surgical. And there's a great sort of speaker bureau that is affiliated with Einstein in New York and Wake Forest, where Swethika's from in North Carolina, with Vanderbilt down in Tennessee, and now with Oregon State on the West Coast. And it provides a way of connecting to some really good speakers from the United States to give these virtual grand rounds. And it's a great pleasure to be able to present Dr. Swethika Sundaravel to talk about LVAD therapy. And she's been very gracious to give her time. I think she cancelled a clinic to do this, right? And we were switching around the date. So she's been really, really, really gracious and flexible. And it's a great pleasure to present her today. A little bit about Swethika. She is self-described an advanced heart failure cardiologist. She specializes in mechanical circulatory support, the medical management of heart transplant patients with cardiomyopathy. She went to medical school in India, then moved to the United States. She did her internal medicine residency down in Florida at the University of Miami Palm Beach campus, then did her cardiology fellowship at the University of Nebraska. She was the chief cardiology fellow, and then she did another more advanced cardiology fellowship at the University of Pennsylvania in Philadelphia. And now she is an assistant professor in the Department of Cardiology and the director of the Genetic and Infiltrative Cardiomyopathy program at Wake Forest in Winston-Salem in North Carolina. She has an clinical interest in heart failure patients, in particular those supported by durable LVADs and those who've received heart transplantation. She is widely published on topics such as adult congenital heart disease in the heart failure population and the use of modern heart failure invasive treatments such as mechanical circulatory support, LVADs, immunosuppression therapy, and the medical management of heart transplantation. And today she is going to give a presentation on the past, the present, and the future of LVAD therapy. And so on behalf of Azrieli, I'd like to welcome Swethika to the group, and I'll hand over to Swethika to talk about the past, the present, and future of LVAD therapies.
And we had many people joining us, so that's good.
Yeah, no, it's good. I'm just letting them in.
Well, thank you so much, Dr. Goodman. That was really kind of you to introduce me. And I really appreciate the opportunity to allow me to speak to an international audience. This is my first talk for Israeli audience, so I apologize upfront if I don't know some of your culture. So let's start with the talk today. I will be talking about the past, the present, and the future of durable LVAD therapy. Again, full disclosure, I designed this talk for an internal medicine cardiology audience. So if there is any advanced heart failure folks in the crowd, this might be just a refresher. So here's the outline of my talk. We'll start with the background about the prevalence of advanced heart failure and the prognosis. We'll talk about the available advanced therapies at this time point, including durable LVAD and a brief touch on transplant. And most importantly, we'll talk about when is the appropriate time to refer patients for consideration. We'll talk about the indications and contraindications to durable LVAD therapy. We'll talk about the history of LVADs to the present day. We will spend a chunk of our time talking about the HeartMate 3 pump, which is the current day workhorse for a durable LVAD therapy. We will touch on the complications of durable LVAD therapy and talk about the contemporary victories and challenges left in the field for us, and then finish with what's in the future. So to start with the epidemiology of heart failure, it affects about 6.2 million adults in America, and I am echoing. Can you hear me?
Guys, please mute those of you.
I think it's better now. So the picture on the right shows you the global prevalence of advanced of heart failure across the world, anywhere between 1 to 5, depending on the reported data. And the chart on the bottom here shows the available registry data across the world for prevalence of heart failure, including the different types of heart failure, preserved ejection fraction, mid-range, or reduced ejection fraction. The prevalence of heart failure, as you can see, increases as the population ages. This graph in the green here demonstrates people who are 80 plus, and the incidence of heart failure in this population is extremely high compared to those who are in the 60s and less than 60. The graph above here shows that historically there used to be a male predilection for incidence of heart failure. However, the women now are catching up with more advancements in diagnostics and more recognition to conditions like peripartum cardiomyopathy and SCAD and things like that. So it's almost an equal incidence in men and women at this time point. Moving on to the stages and progression of heart failure, I'm sure every one of us would have seen this picture on the left in some form of fashion during our medical training. This demonstrates the disease course when a patient is diagnosed with advanced heart failure. This is stage A, where you have the risk factors for heart failure, but you do not have the disease yet. And stage B is where you have the phenotype of heart failure, but you're not symptomatic. When you hit stage C, that's where the symptoms start off and the patients start having acute decompensations, resulting in hospitalization. And this is stage D, which is, elaborated here on the right, where you can see with each and every decompensation, the patients do not get back to their baseline functional status. There's a steady decline in their functional status, eventually culminating in death if they are not, they do not seek intervention. The definition of advanced heart failure when people progress from heart varied depending on which society definition we look at. So the ACC-AHA defines it in a certain way, whereas the European Cardiology Society defines it in a different way. Although the common crux being people who have severe NYHA class 3, class 4 symptoms, people who are not tolerating the routine GDMT medications, having more hypotension, and people who have severe functional impairment. These are the candidates who we should be concerned about progressing to advanced heart failure. On the graph here on the right, you see up top, this is the disease course of a person with congestive heart failure, where here's the onset of heart failure, and then there's a steady decline with each and every hospitalization or acute decompensation. On the graph at the bottom, you see the intensity of care that is required for these patients as the disease progresses. There's a steady increase in the acuity of care that is required for these patients, and that also adds to the burden of healthcare expenditure in these patients. So moving on to the prognosis of patients with advanced heart failure. This is a study looking at the population from the Minnesota Olmsted County that showed that a median survival for patients who had at least one hospitalization for advanced heart failure was really a strikingly low as 50% survival, 50% mortality at 1 year, the median survival being 1 year. This is again another paper showing similar data from about 60,000 US adults. The data was obtained using Medicare claims data after hospitalization. This shows a median survival for heart failure patients about 2 years, which is not encouraging either. So there are some clues for advanced heart failure, which can help clinicians pick up these patients early in the course of their disease. Like we discussed earlier, people who have persistent NYHA class 3 or 4 symptoms, including fatigue and confusion, people who have recurrent hospitalization. By recurrent, I mean more than one hospitalization in 12 months, patients who have severely reduced left ventricular ejection fraction, less than 25%, people who have persistently elevated biomarkers such as NT-proBNP and BNP, patients requiring escalating doses of diuretics, which is another ominous sign, down titration of GDMT medications due to hypotension, dizziness, or fatigue. And then having progressive end organ dysfunction such as renal failure or liver failure. The other ominous sign for advanced heart failure is having recurrent ventricular tachycardia or atrial fibrillation refractory to medical therapy and recurrent ICD shocks. Excuse me. When they progress to end-stage heart failure, this is something that we really do not want to see in our patients when they are referred for advanced therapies. Cardiac cachexia can happen in patients similar to end-stage metastatic cancer, where they are nutritionally at a loss, and this is something that poses a bad prognosis with any form of advanced heart failure therapy. This is a mnemonic that I use often to train my residents and med students. I give them a flashcard when they rotate with me. This is easy to remember to identify advanced heart failure patients. It's called I need help. I for inotrope, need N for NYHA class 4, end organ dysfunction for E, ejection fraction less than 20, defibrillator shocks, recurrent heart failure admissions, escalating diuretics, low blood pressure, and progressive intolerance to GDMT. They don't need to have all of these. If they have one or more of these, then that has to prompt a referral to advanced heart failure provider for further care. When we're talking about advanced heart failure patients, we can classify them based on their acuity and intermax profile, where 7 being the least sick and well-to-do kind of patients who are advanced NYHA class 3, who are still able to do their daily activities, and then progressively intolerant NYHA class 4 would be intermax 5, and then intermax 4 are mostly homebound and extremely limited. Intermax 3 would be the inotrope dependent patients. Intermax 2 being declining on inotrope or stable on MCS support, which is something we're seeing more recently heading into transplant or VAD using a temporary MCS devices. And then Intermax 1 being the critical cardiogenic shock patients who present in extremis. So when we talk about when to refer for advanced heart failure therapies, we always like to say there is no such thing as an early referral. It's never too early. So you want to catch the patients before they decline to stage D, having multi-organ failure and severe malnourishment, cardiac cachexia, to give them the best outcome with any form of advanced heart failure therapy. So the golden window for referral would be someone with persistent NYHA class 3 to 4 symptoms, down titrating GDMT medications, frequent hospitalizations, or having recurrent arrhythmias or ICD shocks, and end organ dysfunction, which can be renal or liver, or progressive confusion causing altered mental status. So these are the patients who would benefit from advanced heart failure therapies. When we talk about advanced heart failure therapies, there are two kinds of therapies that will prolong the life, which is heart transplant or mechanical circulatory support. As we all know, heart transplant is a very scarce resource, which is not available to everyone in a timely fashion. Therefore, we have machines to rescue the patients who are unable to get to transplant, or if they have any prohibitive contraindication for receiving organ transplantation. Here are some of the indications for a durable LVAD. Like we talked about, you need to have a left ventricular ejection fraction severely depressed, less than 30%. The left ventricular size should be at least 5 centimeters or more in order to accommodate the LVAD. A peak VO2 less than 14 ml per kilo per minute, which signifies severely depressed functional status and cardiac limitation to exercise. Stage D heart failure, persistently elevated natriuretic peptides and escalating doses of diuretics, who need unloading. And previously, we used to do the durable LVADs as a bridge to transplant, but however, the community is now moving towards destination therapy LVAD, where people stay on it for the rest of their lifetime. In certain cases where patients who have the chronically stable Intermax 5 to 7 profile can also benefit from getting the durable LVADs implanted in order to improve their quality of life. When we talk about contraindications for durable LVAD therapy, obviously someone who has a preserved ejection fraction with severe restrictive or hypertrophic cardiomyopathy with a small LV cavity, they will not be able to accommodate the LVAD. Someone who has a life expectancy less than 1 year, such as metastatic cancer, someone with severe systemic illness such as ESRD or cirrhosis, someone with psychosocial factors such as homelessness or drug addiction. These are just risky behaviors for damaging the pump. People having hematologic issues such as hypercoagulable states or HIT, these can be relative contraindications. And the other relative contraindication could be people having severe RV failure or ventricular tachycardia or peripheral vascular disease. This picture here shows the timeline of LVAD therapies as and when they were developed. So it started off in the 1990s with the Thoratec and the Novacor pulsatile LVAD systems, which were outside the body, known as paracorporeal or extracorporeal devices, which I'm being told it made a lot of noise, that the patients had PTSD even after the device was removed from them. And then in the 2000s, came the Jarvik device and the HeartMate XVE device. These were totally inside the body, intracorporeal, and then came the HeartMate 2, the HVAD, and the HeartMate 3 device, which is the current day workhorse, at least in the United States of America. At the bottom here, you see the various iterations of these pumps. The Jarvik pump was the first fully implantable intracorporeal device where the outflow graft connected to the descending aorta, as opposed to the current day LVADs where the outflow graft would connect to the ascending aorta. The picture on the right here depicts the HeartMate 3 left ventricular assist device, where you have an inflow cannula. I hope you guys are able to see my pointer here. You have the inflow cannula where it's sewn on to the apex of the left ventricle. And it is attached to a pump head that sucks all the blood from the left ventricle, and there is an outflow graft that is attached to the ascending aorta. So all the blood is being diverted from the pump into the ascending aorta, therefore thereby totally bypassing the left ventricle, which almost acts like a conduit. Like I said before, for someone to be successful with an LVAD therapy, they should have a competent RV to be able to handle the preload that is generated by the LVAD. Um, so moving on to some data behind the LVADs that were approved. The rematch trial was the first of its kind, comparing the HeartMate XVE pump to medical therapy. This was the first machine versus medication trial that was a randomized randomized control trial comparing the XVE versus optimal medical therapy. Even though this was not the perfect pump known to man, you can see that there were a lot of side effects. The survival was still significantly higher compared to the medical therapy group. This was a landmark paper facilitating many more to come. The HeartMate 2 was the second generation LVAD pump, which was based on an axial flow technology, where you can see this is based on the principle of an Archimedes screw. Here's your LVAD, the inflow cannula from the left ventricle, and then it spins around a screw and then goes to the aorta or the outflow graft. So the HeartMate XVE, which is the first generation pump, was a pulsatile LVAD, where you can see there's a diaphragm that goes up and down. So it was creating an artificial pulse. Whereas the HeartMate 2, the axial flow device, was a continuous flow device with no pulsatility. And the HeartMate 2 BTT trial, as we can see on the right here, showed better survival for the continuous flow LVAD compared to the pulsatile flow LVAD. And the side effect profile was also much better for the continuous flow LVAD in terms of having hemodynamic or hemocompatibility related adverse events, which we will talk about in the next slides. Then comes the new era of intrapericardial pumps. One thing I forgot to tell you. So this portion of the HeartMate 2 was intra-abdominal. As you can see, it's below the diaphragm. So the surgery was pretty extensive, and the pump was prone to having more thrombus formation, as the blood was directly in contact with the motor, creating a lot of shear stress and heating. The intrapericardial pumps are the third generation LVADs. The first of its kind is the HVAD or hardware device. The endurance trial was the one that compared the HVAD pump to the axial flow device, which was the HeartMate 2 at that time. This trial showed non-inferiority to for the centrifugal flow device. By centrifugal flow, I mean the hardware device, where the inflow of the LVAD cannula is right here, and the pump head is at the bottom, propelling the blood in a centrifugal fashion. It receives it in the middle, and then it propels it to the side. So the centrifugal flow device was non-inferior to the axial flow device, but the pump was more compact and sat in the pericardium of the heart above the diaphragm. Due to increased incidence of strokes in the post-approval period, this pump was withdrawn from the market due to increased adverse effects. But this did pave the way for smaller pumps, which is the HeartMate 3 pump, which is our current day workhorse based on a magnetically levitated technology, where this is the inflow cannula. Blood comes from the left ventricle, and there is a motor that is magnetically levitated. So there is no direct contact for the blood to the motor. So there is no heat generation because of the magnetically levitated technology. And there is also a large gap for the blood to flow in the pump thereby reducing the shear stress and heat generation, thereby reducing pump thrombosis and cell lysis, which we will talk about in the complications of the LVAD. So as we can see here, this was the landmark Momentum 3 paper published in 2018 that showed better survival for the centrifugal pump, which is the HeartMate 3, compared to the axial pump, which is the HeartMate 2 pump at 2 years in this original paper. We have 5-year data so far showing excellent survival still for the HeartMate 3 device. At 5 years, about 58.4% patients were still alive and doing well on the HeartMate 3 device compared to the HeartMate 2 device. In terms of side effect profile, the most of the hemocompatibility related adverse events, by which we mean bleeding or pump thrombosis or strokes, were extremely low in the HeartMate 2 compared to the HeartMate 3. As we can see, pump thrombosis was almost nil in the centrifugal flow pump. So this paper shows the survival data for patients enrolled in all the LVAD trials compared with heart transplantation, which is still considered the gold standard for advanced heart failure therapy. So the curve in blue depicts the survival for heart transplantation at 2 years, which is about 82%, closely followed by the HeartMate 3 patients in red with 83% survival in the Momentum 3 registry. As we can see here, as a community, we have moved away from doing bridge to transplant LVADs to doing more destination therapy LVADs in black here, by accepting more patients who are not transplant candidates and who have prohibitive factors for organ transplantation, or older individuals who still benefit from this life-saving therapy. This is real-world data from the Elevate registry, which is registry based out of Europe, Asia, and Middle East. This again shows excellent survival for the HeartMate 3 patients with about 63.3% survival at 5 years, with excellent improvement in NYHA class and 6-minute walk distance for these patients. At 5 years, you can see that most patients were NYHA class 2 or 3 or 1, as opposed to baseline where they were NYHA class 4 or 3. Now, what about the INTERMAX registry? So this is the most recent iteration of the INTERMAX registry showing survival outcomes for the magnetically levitated LVAD, which is the HeartMate 3 pump in the current generation. As you can see here, the survival at 5 years for the patient supported on the magnetically levitated LVAD technology is about 64% for all comers. And at 1 year, 93% patients were free of stroke, and at 5 years, 87% patients were free of stroke, which is remarkable compared to the previous generation LVADs, where we were plagued by pump thrombosis and recurrent and strokes. GI bleeding and infections are still a concern, which we are getting better as a community. Device thrombus or malfunction, again, is almost obsolete with the HeartMate 3 device compared to the HeartMate 2 or the older generation pumps. This again is showing the incidence of GI bleeding at 5 years and pump malfunction, which is almost nil. 97% patients were free of pump malfunction at 1 year, 82% free at 5 years of pump malfunction. Here on the right, you see the incidence of stroke. People surviving, 87% patients surviving to 5 years without having a stroke with the HeartMate 3 device. So what about specific data for survival in patients who are younger and have less comorbidities? So this was addressed in the Intermax report from 2024, focusing on outcomes in younger patients who are less than 50 years old, obviously with less comorbidities. And these patients who are supported by the LVAD, HeartMate 3 LVAD particularly, had an exceptional survival of about 72.6% alive at 5 years. This striking survival rate for the younger patients supported with the HeartMate 3 LVAD technology has almost sparked the conversation about net prolongation of life in the heart community. By that, we mean should we try to support the younger patients who have really advanced heart failure on the LVAD therapy for a few years to buy them more time and then definitively get them to heart transplantation, which is a scarce and a resource that's not available for everyone at the right time. So this is a concept that is being talked about a lot in the recent times about prolongation of life. Considering the LVAD and the transplant being sort of mutual to each other. So what about the older individuals supported with the LVAD technology? This is the Intermax report from 2025 showing patients older than 65 years of age. Here you can see they also had excellent survival at 5 years. About 60.2% patients were alive at 5 after being supported on the HeartMate 3 LVAD. And this was regardless of their Intermax class. And they also had exceptional improvement in their quality of life as depicted on the right side here. So this is extremely encouraging, and we are able to offer this therapy to a lot of older individuals who are excluded from the traditional transplant route. So there are some factors which are helpful to predict the success of LVAD therapy. This is a paper that was published based out of the Momentum 3 registry looking at risk predictors for long-term outcomes after LVAD implantation. So certain factors such as having BUN or having a prior sternotomy with CABG or surgical valve procedure. These are pre-implant factors that increased your likelihood of having a worse survival at 5 years after the LVAD. On the post-implant phase, if they had an GFR less than 60, or if they had serious adverse events, ventricular arrhythmias during the index hospitalization after the LVAD, or if they had hemocompatibility-related adverse events, which means bleeding or a stroke during the index hospitalization, they may have adverse poor survival at 5 years. As we can see here on the right, the HeartMate 3 risk score was developed using the Momentum 3 registry also to determine factors that predict survival at 5 years for patients having LVAD therapy placed. So there are several factors included in the HeartMate 3 risk score. Most importantly, the age is one of the risk factors, prior valve procedure or CABG or having a sternotomy. Hyponatremia, having a high BUN, having a smaller LV cavity, less than 5.5 centimeters was one of the risk factors, and having RV failure, as described as a ratio of RA pressure to wedge pressure more than 0.6, was also one of the risk factors for having an adverse outcome after the LVAD. So these factors were weighted, and that adds to the prediction model for having adverse outcome after the LVAD surgery. So now we talked about how good the pump is. It's almost like it's a pump that never stops giving, but there is no such thing as a free lunch We can talk about some of the complications that come with the LVAD therapy. Talk about complications from the LVAD therapy. We can sort of group them into two categories, one being the hemocompatibility related adverse events, or the second group being hemodynamic related adverse events. By hemocompatibility, we mean the adverse events that happen due to thrombosis or bleeding, because of exposure of blood to the motor pump. And like I said before, the hemocompatibility related adverse events like stroke and thrombosis have almost become obsolete with the newer generation HeartMate 3 pump. In terms of bleeding, as we will talk about in the next slides, we are also improving on that front with the HeartMate 3 device. In terms of hemodynamic related adverse events, right, heart failure and aortic insufficiency, these tend to be really debilitating after the if the patients have it after the LVAD. And we will talk about strategies to mitigate them in the next few slides. We can start off with bleeding post LVAD. The pathogenesis behind mucosal bleeding after LVAD is mostly related to shear stress and lysis of the von Willebrand factor, almost causing an acquired von Willebrand syndrome, instability of the GP1B9 particle, causing angiogenesis and platelet dysfunction, leading to bleeding and forming tiny blood vessels in the submucosal area called AV malformations. And sometimes the bleeding in the mucosa can be so diffuse, as you can see here. This is the picture of an endoscopy where it's even hard to identify the source of bleeding. And the mucosal bleeding can happen in any mucosal lining, not just the GI system, but it can manifest as epistaxis, or in some people can also have they can also have a bleeding in other genitourinary systems as well. The strategies to mitigate bleeding post LVAD include lowering their INR goals, making sure they are adequately optimized from an LVAD standpoint by, making sure their right heart pressures are, the RA pressure is less than 12 and wedge pressure is less than 18. Those are some of the factors that have shown to prevent GI bleeding in the future. There's also been success using octreotide to treat GI bleeding secondary to AV malformation. And there's some data suggesting the use of ACE inhibitors and ARBs to prevent the neoangiogenesis, as we can see here. This was a single center study looking at patients who received an ACE inhibitor or ARB post LVAD placement, and they did have numerically lower incidence of GI bleeding, was statistically significant compared to those who did not receive it. This is a recent paper that was published in the Gastroenterology Journal supporting the use of octreotide versus standard of care in angiodysplasia-related mucosal bleeding. We have been using octreotide for a long time in GI bleeding associated with AVMs in LVAD-supported patients, and it has worked greatly for a lot of our patients. Once again, the GI bleeding used to be a huge burden in the HeartMate 2 devices and the older generation pumps. With the HeartMate 3 devices, we are seeing less of GI bleeding, but not completely gone. That will bring us to the Aries HeartMate 3 trial, which is another randomized control trial that studied the use of aspirin versus placebo in patients who were supported with a HeartMate 3 device. Enrolled more than 600 patients. They were also on baseline warfarin for anticoagulation. This was a practice-changing landmark trial where you can see that patients who were on aspirin therapy had significantly higher incidence of death or non-surgical major bleeding-related adverse events. So this paper came out in 2023, and since then, as a community, people have not been using aspirin in patients who are supported with the HeartMate 3 device. Once again, it's a HeartMate 3 device, not for HeartMate 2. It's a HeartMate 3 device that's very forgiving and has the ARIES trial showed benefit for no aspirin in this population. There was a sub-study of the ARIES trial that just came out looking at patients who had an LVAD, and additionally, they also had atherosclerotic cardiovascular disease, such as CAD or having a prior stroke. There was all this question about, hey, can I stop the aspirin in someone who's had a PCI? But this study now shows that even those patients were better off without aspirin compared to placebo therapy in patients who are supported with HeartMate 3 LVAD and who are on warfarin at baseline. Moving on to the next complication, pump thrombosis. Once again, this is another obsolete thing with the HeartMate 3 device. Here you can see various examples of pump thrombosis. This is a heartwear device where you can see thrombus sitting in the inflow cannula. This is a HeartMate 2 device showing thrombus along the screw. And you can also have thrombus formation along the outflow graft. As you can see in this picture, it can happen along the graft, or it can happen at the attachment site to the ascending aorta, causing acceleration and flow and causing power spikes in the pump on interrogation. The management for this, some people lytics, some people use 2B3A agents for thrombolysis. Most of these patients present acutely with congestive heart failure and power spikes on their LVAD interrogation. This, if they do have a large enough thrombus, then it can be a devastating situation that requires an urgent transplant or pump exchange. Moving on to the hemodynamic related complications. This is still a very important complication that we deal with in patients with LVAD therapy in this day and age. RV failure post-LVAD is a very debilitating condition for patients having some LVAD support. The pathogenesis of RV failure post-LVAD, there are multiple theories for this, but the most important one is the septal shift that happens, the septal shift that happens after the LVAD implantation. So the LVAD, as you can see in this picture, exerts a constant negative pressure in the left ventricle, sucking all the blood out, thereby shifting the interventricular septum towards the left ventricle. Believe it or not, about 60 to 80% of RV ejection fraction comes from the longitudinal strain of the septum, thereby the septal shift after the LVAD placement causes RV dilation and decreased RV function, causing RV failure. The definition of RV failure post-LVAD, there have been multiple iterations of this depending on which paper we look at. The most widely adopted definition is the Intermax definition, which goes by elevated RA pressure more than 16, plus manifestation of congestion such as peripheral edema, ascites, hepatomegaly, or renal or hepatic dysfunction. Implication of RV failure post-LVAD can be multiple. It's not just the hemodynamic abnormality, but it can also exert major effects on the end organs, such as renal dysfunction and hepatic dysfunction from passive congestion. You can have florid renal failure, especially in the fresh post-op period. which is also vulnerable for ATN. These patients need to be recognized really quickly and acted upon to unload the right ventricle to prevent fulminant liver and renal failure. Interestingly, RV failure also is associated with hemocompatibility related adverse events such as GI bleeding and strokes by causing congestion in the mucosal submucosal area. So there are some predictive models that have been designed for predicting RV failure post LVAD. As you can see, there are multiple groups that have worked on this. However, a systemic review here shows that none of these models are have been validated successfully in the validation cohort. The most useful parameter that I use on a day-to-day basis is the RA pressure to wedge pressure ratio, which is easy to calculate at the bedside, and the PAPI, which is also an easy hemodynamic parameter that can be calculated at bedside to help predict RV dysfunction post LVAD placement. When it comes to management of RV failure post VAD, like I said, early recognition is the key to success here. Always target a preload of less than 12 for the RA pressure in order to offload the central venous system. We can use diuretics or ultrafiltration or renal replacement therapy, whatever it takes to remove the fluid and decongest the RV. Using inotropes is also very common in the postoperative state. And then some people have, some programs have the tendency of upfront utilization of right ventricular support device based on certain preoperative risk factors. Some programs are more reactive to things that may happen in the OR if the surgery is prolonged, a lot of bleeding, receiving multiple blood products. These are certain factors that can tip the RV into dysfunction and failure, requiring mechanical circulatory support. There is no consensus on upfront versus later RV support device. It is institution-based practice at this time. Moving on to infections, this is another debilitating complication that we still see in this day and age with our LVAD patients, especially as the destination therapy population increases. The driveline site, as you can see, this is the wire that controls the LVAD. It comes out in the abdomen, and this area is prone to tugging and erythema, and can have infection that can extend all the way to the pump. The picture above here is a PET scan image of showing the area of infection. Up here is localized to the driveline site. Over here, it's extending to the almost the pump head here. Over here, the infection is in the outflow graft. And over here, starting from the driveline to the pump, all the way here. The risk factors for driveline infection include abdominal obesity, sweating, and people who are very active outdoors. We see that here in our farmers and people who love spending time outdoors. The tricky thing here with driveline infection is that once it's infected, it always stays infected, unfortunately, and the MSSA can soon become an MRSA driveline infection as the resistant pattern creeps up quickly. We can use antibiotics to treat them. We can use suppressive antibiotics. We can debride them. Some places also try to reroute the driveline to a different site. And then some programs are trying phage therapy, bacteriophage therapy for resistant organisms such as MRSA. We are hoping the next iteration of the LVAD may come with a fully implantable driveline, which may help with this driveline infections. As you can see, the incidence of driveline infection at 5 years on this Intermax registry is about 61%. That's freedom. But this is the same for all kinds of pumps, and we have not moved the needle here with the advancement in technology from back in the day, HeartMate XVE to the HeartMate 3 current generation pump. Moving on to valvular diseases, the most common and most important valvular disease that we see in patients with LVAD therapy is aortic regurgitation. This is a patient of mine who's had a HeartMate 2 LVAD for 10 years now. And you can see that the aortic regurgitation here, it's almost oh God, 1 second, sorry. It's almost a continuous jet of flow in systole and in diastole, increasing his left ventricular chamber size and causing mitral regurgitation here. So quantifying aortic regurgitation in LVAD patients can be challenging. There was a group that looked at diastolic acceleration velocity to quantify the severity of aortic regurgitation. You can see the steep slope for severe AI. Interestingly, aortic regurgitation has also been associated with adverse events like GI bleeding and stroke in patients who have AI compared to those who did not have AI, which was statistically significant in this small population of study here. When we do find aortic regurgitation that is significant on echo, we optimize the pump speed by decreasing the speed to decrease the afterload for the aortic valve and help enable aortic valve opening and promote more contractility to enable aortic valve opening to mitigate the aortic regurgitation. In severe cases, there have been cases where they tried a TAVR valve for these patients with severe AI post LVAD, and that has been successfully done as well. Moving on to arrhythmias, this used to be a question that was always debated at all the meetings. If patients who have an LVAD were supported by an LVAD, do they still need a defibrillator or not? I think we have an answer now. This was the most recent study from the Momentum 3 database that they analyzed patients who had an ICD and who did not have an ICD were supported by HeartMate 3 device. They found that people who did have an ICD had higher rates of ventricular arrhythmias and ICD shocks, otherwise stable the arrhythmia. So people who did not have the ICD had no difference in survival with people who had the ICD. The theory here is that even with the ventricular arrhythmia, your heart is supported by the pump. Therefore, people cannot have any symptoms, even if they are in ventricular tachycardia or ventricular fibrillation, like this gentleman of mine who presented to the ED feeling dizzy. And we can all see the LVAD artifact here causing some artifact on the baseline tracing. However, you can see underneath that there's fibrillatory waves and the patient was having low flow alarms on his pump with ventricular fibrillation. But he was awake and talkative that made the ED doctor not believe that he was in VFib. This is a study looking at the incidence of ventricular arrhythmias after LVAD placement. This was a single center study that showed about 12% of patients had sustained ventricular arrhythmia in the first 30 days after LVAD placement. And those patients who did have sustained ventricular arrhythmia in the early postoperative phase had worse mortality compared to those who did not have ventricular arrhythmia in the first 30 days. This is another paper from the Baylor group in Texas showing the feasibility of VT ablation in patients who have VT after LVAD placement. So people who had VT ablation had a better survival compared to those patients who did not have VT ablation, even though supported with the LVAD. The things that we want to rule out when patients have VT during having an LVAD is most importantly rule out mechanical issues such as suction events. So get an echo to see the cannula position and make sure it's not close to the septum, causing mechanical VT. Cannula malposition can cause VT also. Decompensated heart failure, believe it or not, can still cause VT in patients having who are supported with the LVAD. Electrolyte imbalances are also common in these patients. Another registry from Germany and Switzerland looking at patients who had VT ablation who are supported with the LVAD therapy. This was technically feasible, but really challenging procedure, having about 14% mortality at 30 days post-ablation. Although the procedure was feasible and they did have remission from VT in both ischemic and non-ischemic patients, as we can see here. Moving on to external outflow graft obstruction. This is one of the more recently recognized complication in the HeartMate 3 pumps, where you can see this is the cross-section of the outflow graft here, and the area of the lumen of the graft is compressed extrinsically by debris accumulating around it, and this can cause severe obstruction to the outflow graft. As you can see on the CT here, this is all thrombus, and here's the lumen. And this can cause flow acceleration on your echo Doppler profile when we are imaging the outflow graft, and causing low flow alarms and pump dysfunction based on the degree of obstruction. And this sort of obstruction can happen anywhere along the line of the outflow graft. It can happen at the bend relief right here, or anywhere kinking along the outflow graft, or stenosis at the attachment to the ascending aorta. Depending on the area of obstruction, this should be a surgical fix or a percutaneous fix using endovascular stenting. We have had success with endovascular stenting and surgical fix for this condition. Sometimes it's very tricky to operate on this because the outflow graft is right underneath the sternum in some patients, especially when they have weight loss and there's movement of the LVAD. So this is a condition that is being increasingly recognized in the recent times as we have more patients being supported on the LVAD therapy. To end on a positive note, recovery after LVAD therapy is also possible. This is data from the Restage Heart Failure trial, which prospectively enrolled patients who were receiving LVAD therapy to a very rigorous medical therapy, medical and device therapy to optimize their heart failure regimen to see if they will recover their heart function. And as you can see up top here, about 47% of patients were explanted in this group after having myocardial recovery. These are some of the variables that were associated with having recovery at the time of implant. Obviously, having a younger age, females, and non-ischemic cardiomyopathy were associated with successful recovery. And these patients were also found to have sustained recovery of their LV function up until 5 years, not requiring any advanced therapies or heart failure relapse. This is a study looking at the intermax population for recovery. As you can see, the incidence of recovery or explantation was really low in the all-comers in the Intermax registry compared to the restage heart failure registry, which really had a rigorous protocol for medical management post-LVAD therapy to help improve myocardial recovery. To summarize, we have really come a very long way in durable LVAD therapy. The pump size has gotten better. The side effect profile has gotten better, although there are certain complications which are still kind of like the Achilles heel in this field for us, including RV failure and driveline infections, which we are hoping to get better in the next iteration of pump. There are work being done for the fully implantable pump or the other transcutaneously chargeable pump that is being in the works for now. The other thing that we also want to focus on is improving the quality of life for our patients after LVAD therapy. At some point, we could, design a pump which is a rate-responsive smart pump, which could speed up during the time of exercise. These are things to be food for thought. And these are the new LVAD devices that are being studied now. The AVA Heart device is one that is being actively studied. We are enrolling patients for this AVA Heart trial. This is another intrapericardial pump. There are other devices being explored. As I said, there are people studying transcutaneous energy transfers, which may eliminate the need for a driveline. And then really hot off the press is apixaban use for LVADs. Historically, I believe they studied dabigatran in the past for LVADs, and they had increased incidence of thrombosis. So DOACs were not used for LVAD patients. But these are two small studies that were recently published showing the feasibility of using apixaban for carefully selected LVAD patients. The one on the left here is a single center study using apixaban for a carefully selected group of LVAD patients, and they did have better bleeding profile using apixaban compared to warfarin. That was not statistically significant, but the number was really, really small. On the right here is a randomized control trial using 45 patients. The DOT HeartMate 3 study that showed the apixaban population was non-inferior to the warfarin population and more feasible. The final results are still awaited from this study. So these are my takeaways after today's talk. Heart failure is a progressive disease. Early identification of advanced heart failure is the key to improving survival and outcomes. Please remember the I need help mnemonic to help identify these patients. VADs do work, and they do work really well. The quality of life is so much improved, and the survival is astounding and almost comparable to heart transplantation for the right population. We are getting better with mitigating the adverse events, and we are still faced with the Achilles heel of RV failure, aortic regurgitation, and driveline infection. These are the most common reasons to transplant someone with an LVAD in this day and age. And last but not the least, the future looks really bright for LVAD therapies. And I will take any questions if you have. Thank you for letting me present to you today. I hope I was able to educate some of and shed some light on LVAD therapies.
Swethika, that was fantastic, because as a dumb surgeon, I didn't know very much about any of this. So I now feel very well informed. Ido, would you care to comment? Maybe ask a question? And anybody else, would you like to comment?
Thank you very much, Swethika. A great talk. we had some students and general cardiologists, so I thought that it was a fantastic talk with all the basic stuff. And I really want to thank you for giving us this talk. Any questions, guys?
Can I ask a couple of questions? Again, without
Of
any
course.
prior knowledge. So maybe Swethika, how much are these devices? How much do they cost in the US? And Ido, do you know how much they would have cost? In Israel?
680,000 shekels, and it's yours.
Yeah, it's
So
about 500,000 is what I
yeah,
was told. It's not just the implant, but the long-term care that these patients need, including INR checks,
right,
driveline dressing material, and labs and frequent office visits, equipments. Yeah.
The device
so
itself in Israel, Elliot, cost around $100K.
right,
And
right,
similar in the States. In the States, I think we paid a little bit more, if I
right.
recall correctly.
And
Um,
economically, how does that compare with transplantation in the long run?
so it's
With card,
within the budget, so it's like no cost for the patient in Israel.
right?
Um,
But to
in,
the
in the
system,
States, there was like a change in the listing criteria in 2018. So today, most of the VAD patients, correct me if I'm wrong, Swethika, or DT and not BTT.
Correct. Yes. The
Um,
change in the listing system happened
yeah,
in 2018, and
that was a big issue for the MCS people. Uh, so more use of temporary devices and less of like durable devices.
right? So
correct.
and then economically, how does that compare over a long period of time in terms of cost versus transplant? Got to be cheaper, no?
It's not
I
cheaper.
think
It's not.
with transplant, you get more testing that annually you get angiograms and frequent biopsies for monitoring for rejection.
Right.
The LVAD, though, once you put it in, unless you have a complication, we don't routinely, do angiograms. We do right heart catheterizations, but less of a hassle, I want to say, having
Right.
dealt
Yeah.
with both these
And then
patients.
when you factor in the cost of the immunosuppressives, how
Correct.
Yeah.
does that make
Wait,
LVAD cheaper?
at UPenn, they continue to do right heart caths after I left, or they stopped it?
We do at 6 months for the VAD optimization,
Okay.
speed
I started
optimization
at
study.
3 months, and every 6 months afterwards.
Uh-huh.
Yeah.
Yeah,
People hated
so
it. I was the only one who was doing it.
I think it's different practice across different institutions. Here at Wake, we do it before discharge because the patients come from really far away.
Okay.
So yeah, at least once between 3 to 6 months to see if the VAD is actually doing what it's supposed to and supporting
Okay.
the patients, especially with exercise
Yeah, I
for
loved
the
it. I
younger
was the only
DT
one who liked
patients.
doing it, but yeah.
Yeah.
Okay.
Is there an age limit?
No. We
None.
had an 81
Technically,
years old.
no. The latest Intermax data, 2025 had excellent survival for the people more than 70 years old.
Right.
So we recently at our institution did 77, I think.
So at UPenn, I did 81.
Oh
Oh
wow.
wow. Okay.
Yeah.
Yeah.
And he survived like 3 years. He was a good guy.
Yeah. And
Right.
that was a HeartMate 2 or a 3
No, it was HVAD, I think.
HVAD, yeah.
It was like
So I
back
think
then.
the HeartMate 3 is more durable and more forgiving. It's a really excellent pump.
At the age of
Um,
81, durable is like relative.
Yeah, I guess it is relative term. Very interesting.
So,
Anybody else?
Watika, thanks a lot.
Thank
Fantastic.
you.
Thank you
Thank
very,
you
very
for the
much.
opportunity.
It was a
Uh,
great
f-
I'll
kickoff
see you
event.
shortly, hopefully in ISHLT or at the local conference.
yeah, we'll meet in Toronto. Yes.
Thank you,
Good night,
everybody.
everyone. Thank you,
If folks
everyone.
don't mind to fill out the
Oh,
survey,
yes. If you look on the
if you could
chat,
take a minute to do
yeah,
the survey,
look on
that'd
the
be
chat.
helpful for me. Thank you.
There's a survey monkey for people to fill out. Just look at the chat and click on it. That would be very helpful for Swethika.
I don't have
Okay.
I don't have anything on the chat.
There's nothing on the chat?
Maybe we should send it out again for people who joined later.
Uh, Let me have a look. Maybe I
Thank
did
you
it
so
just
much,
before.
guys.
Okay, I'm just putting it back on the chat
Oh,
before everybody should leave. And thanks for attending. Fantastic.
Bye
Great
bye.
Thank you,
stuff.
Dr. Goodman. Thank you, Dr.
Thank you,
Brody. Thank you,
Swethika.
everybody.
Ilan,
Have a
great
good
pleasure
night.
meeting
Good night.
everybody.
Bye.
Thank you. All right. Chag sameach.
Thanks,
Bye-bye.
Sam.